Good morning, everybody, or afternoon or evening, wherever you are. Just giving it another moment for people to log in. Moment by my timing. Hello, everybody, and welcome to our May 5th event of the 6th International Symposium on Intrauterine Devices and Systems for Women's Health. Today we have two presentations, expanding IUD service to adolescent, transgender, and post-abortion patients, and access to IUDs, real-life challenges to bringing evidence to policies and practice. And you see here our faculty for the event and our agenda for the day. This event is accredited and it is being recorded. If you would like credit, you will need to complete a course evaluation, which will be distributed after the webinar. Conflict of interests are disclosed here. And we would like to acknowledge our supporters, the financial supporters, Thayer Healthcare, Cooper Surgical, the Hewlett Foundation, and our sponsors, Mona Lisa and Sabella Pharmaceuticals. And now I would like to hand the microphone over to Anita Nelson, who will be our first moderator.
Thank you, Rachel. Hello, everybody. I'm very pleased to moderate this first session for IUDs for special populations. But before I introduce our absolutely terrific speakers, I want to personally thank and acknowledge Dr. David Hubacher for reminding us all that it had been quite a long time since the 5th International Symposium. And I want to thank Carolyn Westhoff for giving this symposium a home at Columbia and for giving us access to her wonderful staff, Rachel, whom you just saw. Now, earlier sessions of this conference have covered a wide range of medical issues around IUD use and access issues, certainly in this country and around the world. We've been very lucky to have the pioneers in these fields on each of the topics present their own work. And today it's exactly the same thing. And if you have missed any of the earlier sessions, they are available online for free. You just won't be able to get continuing medical education, but you can certainly drink in the knowledge that they offer us. Now, again, today's session, actually, that you just heard about, contraception for special IUDs in particular for special populations, is really a great example of why we needed an update, why we needed the 6th symposium. Because if you think back on it, the populations we're talking about, by and large, were not even on the radar of clinicians for the earlier symposia. So we are very, very happy to bring you these new topics and to update the whole field. Our first speaker is a wonderful example of these pioneers. Dr. Stephanie Teal is professor of obstetrics and gynecology, pediatrics, and clinical sciences at the University of Colorado School of Medicine, where she's also heads their very productive family planning fellowship. She is the immediate past president of the Society for Family Planning. Now, she has been deeply involved at many levels in contraceptive research, advocacy, innovative program development, and policy implementation. Because of her landmark work introducing effective contraception to postpartum teens throughout her whole state, we've asked her today to speak about delivery of IUDs to adolescents. Dr. Teal?
Thank you so much, Anita. I really appreciate the introduction, and thank you, Drs. Westhoff, Hubacher, Nelson, Blythe, and the others of the organizing committee for inviting me. I'm just pleased to be here. So as Dr. Nelson pointed out, this talk does not really stand on its own. It's part of a series. I wish it was all in one day together in San Francisco, but that's not how it happened. So I am not going to review IUDs in depth because we've already had several fantastic lectures to this point. I'm going to take off right from where we left off last month. So next slide, Rachel. And there'll be a lot of next slide because Rachel's the boss here. There we go. Our learning objectives today actually are going to focus very, very specifically on the adolescent, not how to put an IUD into an adolescent or even really specifics about misoprostol or numbing people up or whatever. We're really going to talk about who adolescents are and understand how normal psychosocial development impacts how adolescents want to use contraceptives. We're going to debunk myths around adolescence and IUD complications, and we are going to talk extensively about the state of being an adolescent and where autonomy and the need to develop as an autonomous adult fits into the use of contraceptives. Next slide. And my disclosures are that I do a lot of contraceptive research funded by some very generous pharmaceutical companies. I'm also funded by the National Institute of Child Health and Human Development, and I serve on a data safety monitoring board from Merck. My main disclosure is that this work that I'm going to talk about today is a team effort. I'm so proud to represent our team, but I want to give a special shout out to some of my collaborators at BC4U at Children's Hospital, including Janelle Sheeter, Liz Romer, Molly Richards, David Kaplan, and others. Next slide. So I'm going to jump right in with what is adolescence. Adolescence is not puberty. If you remember nothing else from this talk, this is the slide I want you to remember. Puberty is the process of physical growth and development that transitions children to adults. This can happen in a vegetative state. It is a purely physical process. Adolescence, on the other hand, is a process of cognitive, psychosocial, and moral growth and development that transforms dependent children into independent, self-sufficient members of society. For those of us who focus on adolescent health care, it is so key to understand that adolescence is an actual time between childhood and adulthood, and adolescents have their own framework for looking at the world. Next slide. So what is adolescence? Well, the problem is trying to define a psychosocial, cognitive, and moral process development by categorical ages. So nobody really knows. Here's some of the definitions. WHO says adolescents are 10 to 19, young people 20 to 24, CDC, healthy people. Everybody uses different numbers. Next slide. But what I really want to point out to people is that, again, those of us who work closely with adolescents, don't worry too much about whether she's 19 or 21 or 17 or what. We really focus on the why of categorizing people as an adolescent, which is that the risks of this stage, the risk of violence, suicide, accidents, sexually transmitted infection, preterm birth, unplanned pregnancy. Those are the risks of a not fully developed frontal lobe, and that persists through the early 20s. So much of the data that I will show you as I talk about adolescence, really we use up to about 24 in our clinical and research settings. Next slide. So teen sex and contraception. Go ahead, Rachel. 70% of women will have penile vaginal sex by age 19. Go ahead, Rachel. Yeah, there you go. The median age of coitarchy in the US is about 17 years old. 52% of high school students say they used condoms the last time they had sex, meaning 48% of students said, no, last time I had sex, I didn't use a condom. Next. And of sexually active high school students, unfortunately, if you say, well, what about a non-condom contraceptive? You have about 3/4 who say, oh, no, I didn't use anything. Maybe I used a condom, but I didn't use anything else. Next. Which leads us to unplanned pregnancy in adolescence. Now, this slide actually only goes to 2013. I really need to update it. Sorry about that. But what you see is that we've had continuing declines in pregnancy rates. And for those of you with interest in this field, which is probably 99% of us, you know that in fact the rates have continued to decline with some disparities between racial and ethnic groups, with the greatest decline among Black and Latinas, but the lowest absolute rate among white people. Next. Okay, another point I want to make that those of us who don't take care of adolescents may not think of initially is that when we talk about the unintended pregnancy rate writ large, with a whole state, province, or nation as the denominator, we're assuming that most everybody in the denominator is sexually active. It's really important to realize that when we're talking about pregnancy rates in adolescence, remember that only 50% of adolescents have ever even had sexual intercourse by 17 and a half. By 19, we're at about 70%. So we use a denominator typically of an age group, but really if only half of that age group is exposed to the risk of pregnancy, the rate is actually double what we're used to seeing when we only look at sexually active teens. So it is a really, really high risk. Now, teen pregnancy, interestingly, is mostly not due to method failure. This table is from PRAMS, which is the Perinatal Surveillance Database, meaning people who, or in this case, teens, who actually became pregnant and gave birth. So among these teen mothers, when they were asked and they could answer more than one answer, how come they got pregnant? In fact, very few said it was because they couldn't get birth control. It was because they just weren't using contraception. They didn't think they could get pregnant. They assumed that they were sterile. And this is why I want to spend the bulk of this talk on the adolescent brain and how we speak with adolescents. Next slide. So for us to have an impact, we need to take a biobehavioral approach and recognize that providing effective medical care to adolescents requires appreciating their psychodevelopmental stages. Next slide. So what makes docs and nurses and providers dread interacting with adolescents? I'm not going to read all of these off. For those of you who work with adolescents, you're looking at this and laughing. For those of you who can't stand working with adolescents, you're looking at this and breaking out in a cold sweat. Next slide. But let me just point out that adolescents actually dread us as well. Why? Because we are a barrier, a threat to their burgeoning autonomy. We minimize the seriousness of their lives. Oh, don't worry, it'll get better. Oh, I know you think you're madly in love, but you're going to head off to college and forget that person. They dread being judged, disrespected, minimized, and they look at us and we may feel kind of young, but we're not. And we have a natural alignment with the parent. Next. So let's talk about early adolescence for a minute. 11 to 14 is what I put up there. Again, it is not a chronological stage. It's a developmental stage. The main tasks of the adolescent at this stage is coming to terms with their new body image, putting on weight, developing breasts and hips. And the major threat to their health is denying their emerging sexual identity, attempting to infantilize young people as they move from childhood to adulthood is actually a major threat to their health, because denial is the opposite of information. And I know we have a very international audience, and this is very much a US problem. And other, it's quite variable by culture. So at this stage, we talk about moving from one level of intimacy to another and back again. Just because you did something with someone else or last week doesn't mean you have to do it this week. We talk about what makes a good partner. How do you pick somebody? And what misperceptions do young people have that can become entrenched concerns? Next slide. In terms of middle adolescence, at exit from middle adolescence, about half will have had penile vaginal sexual intercourse. Sexual experimentation is absolutely normative. That is the norm. It is accepted. It is, whether it's accepted on a societal level, it is accepted by clinicians that sexual experimentation will happen. Next slide. The major developmental task at this stage is developing a personal identity. Who am I? Role experimentation is normal and yet is the major threat to health and safety. Provoking a reaction in onlookers helps middle adolescents gauge the relative merits of each of the identities. Am I a ballerina? Am I a goth? Am I a punk rocker? Am I a preppy? Different personas. Am I bisexual, pansexual, heterosexual, cisgender, transgender? All of this role experimentation is expected, normal, and denying it or provoking more extreme reactions is a major threat. Next.
3 minutes, Stephanie.
Thank you. So moving on to, I kind of feel like the introduction went into my time, but in terms of late adolescence, we're really moving into this diminished but not fully resolved need for risky provocative experimentation. Next slide. So best practices for adolescents are increasing people's ability to have more intimate relations, increasing their comfort with and enjoyment of sexual behaviors, and focusing on avoiding sexual morbidity without using scare tactics. Next slide. In terms of IUDs for teens, this is really my only slide summing up that there is no increased risk of PID, no increased risk of tubal infertility or ectopic pregnancies related to early use of IUDs. IUDs are safe and acceptable in nulliparous, but they are not the default for everyone. Next. 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 Okay, so I want to tell you a little bit about placing IUDs in adolescents. This is a study that I did again with Dr. Romer, Dr. Sheeter, and others, in which we took paras and nulliparous teens. Next. Oh, next. Usually I'm clicking these myself, so I'll for the next. And you see that there are certainly differences between the groups. Next. But what we see is that with only 1% requiring ancillary measures, we were able to successfully place IUDs in adolescents with the first attempt 96% of the time, regardless of nulliparity. Next. And I wanted to point out who the providers were of these initial IUD attempts in adolescence, which was mainly advanced practice clinicians. Next. Next, the youngest patients did have a smaller uterine sounding depth, were more likely to be nulliparous. Next. But had no increased risk of failed insertion. Next. And we'll skip this slide. Thanks. So then the next question is, do adolescents want long-acting contraceptives? And the answer is, when they are offered, they do. Next. Does LARC really reduce unintended pregnancy in adolescence? And the answer is yes. Next. So just to sum up, I want to encourage us all to center the adolescent patient. Contraception is the entree to adulthood in healthcare. It is some of the first times that children now are seeing adult providers, and that is us. Next. This interaction sets the tone. Go ahead and keep going there. Respect is the most important gift we can give to teenagers. Some adolescents do desire parenthood, and by not respecting their autonomy, we are actually impacting their ability to succeed within the healthcare system for the rest of their life. And I would posit that talking people out of discontinuing a method because you believe that they shouldn't get pregnant is a form of assault. Next. It's very important to remember that although many providers say they feel comfortable with IUD use in nulliparous and in teenagers, that doesn't always translate into the practice. And I want to encourage all of us to step 1 or 2 steps beyond our comfort zone with adolescents after this talk. Next. And go ahead. And to remember that when we are uncertain of the suitability of IUDs, that's our 5 o'clock box, we miss the opportunity to increase IUD awareness and knowledge. Patients with too little information to request IUDs don't talk to us about them. We perceive indifference or disinterest, and then we are continually uncertain. Next slide. And so I'm just going to put up here the clinical pearls for the youngest patients. Respect them, make it very, very easy to stay non-pregnant as they move through this really challenging time in life. IUDs are a great choice when effectiveness is the top priority and have few contraindications. Thank you very much.
And thank you, Stephanie. That was absolutely wonderful. Really appreciate your talk. And we are looking forward. I forgot to announce earlier on that if you have any questions, please do put them into the chat box. Our speakers will look at them, and we have a Q&A at the end of the session. Well, moving on next to our next speaker, Dr. Jen Hastings. She's a assistant clinical professor at University of California, San Francisco, Department of Family and Community Medicine. She was the founder and director of Transgender Health Care Services for Planned Parenthood, Mar Mounty, from 2003 to 2018, and supported the development of national protocol and guidelines for the Planned Parenthood Federation of America. She is a member of the Medical Advisory Board for the UCSF Center of Excellence for Transgender Health and Transgender and Gender Expansive People in the United States, and a national consultant for transgender health care, increasing medical access and understanding. You can readily see why we've asked her to talk today about delivering IUD to non-binary and gender expansive people. Thank you so much, Jen.
Thank you so much, Anita. It's just an honor to be here and great to follow after Stephanie, because you will find in your practices that an increasing number of adolescents and transitional age youth are coming to your offices, sharing a non-binary gender expansive identity, transmasculine. And so I think it's great that we get to talk about this today. And my one sort of take home that I'll share in terms of what I'm hoping you'll all think about is language. So today's symposium is for women's health. And actually, I would love for us to expand who we're serving, because it's actually trans folk often don't, actually, the transmasculine folk assigned female at birth may not resonate with the term women's health. Next slide. So in your offices, you may see Sam. And this is a composite person, obviously, in the sense that this person could be anywhere from 13 to 45. And when you see this person checking in or coming into your office, you may make the assumption that this person can't get pregnant, doesn't have a uterus, doesn't need contraception, and doesn't need an IUD. But let's try to learn about Sam. Next slide. So what do you need to know in order to serve this person in their life in terms of their reproductive health, their contraceptive needs, and their future fertility? So you want to make sure that in your offices, you have the ability to elicit their gender identity and pronouns, what actually is happening sexually, their partners and behaviors. Make sure you have an anatomical inventory in your electronic record or in your intake papers. Does this person have a uterus and ovaries? What are their desires for future fertility? Are they on medications that might impact their fertility or their life? In this case, potentially testosterone. Is menstrual cessation a goal for this person? And are they able to tolerate a pelvic exam, which would be very relevant in the case of putting in an IUD. Next slide. So let's learn about Sam. So this Sam is non-binary. The pronouns that Sam asks for are he, him, or they, them. And this is much increasingly common that people will be comfortable with two sets of pronouns. In this case, Sam does still have uterus and ovaries. He has had chest surgery. Sam has been on testosterone for 2 years, no longer menstruating, and their sexuality has evolved to poly and pan. And Stephanie used some of those words, but some of you may say, what does that mean? And so polyamorous is someone who's involved in multiple romantic relationships, and pansexual means that they're comfortable or sexually attractive to people of all genders. Sam shares that when they started testosterone, they were told by their provider that testosterone would make them infertile. But now Sam is hearing that pregnancy might be possible, even though they've not been on a period for about 1.5 years. And Sam is thinking about getting pregnant in the future, but has learned about the process of harvesting eggs potentially, instead of Sam themselves being pregnant. Okay, so Sam has heard about an IUD and is interested. So let's see what we want to think about. So I want you to think about language. So when someone shares they're transmasculine or a trans man, that person may still have a uterus or ovaries, typically assigned female at birth. And I have in orange here the gender terms that you may be seeing where you might be thinking about contraception, in the sense that there might still be a functioning hypothalamic pituitary axis and a uterus and ovaries, and pregnancy as possible. So you'll see more, as I shared already, non-binary and genderqueer, gender fluid folks. Also, folks will share their identity as gender expansive or gender non-conforming. And I'm guessing that most of you know the term cisgender. That's where your gender identity is congruent with sex assigned at birth. And obviously cisgender women may still need contraception. I didn't highlight that in orange. Next slide, please. So I wanted to spend just a few moments talking about sexuality and fertility, because I think There's oftentimes assumptions that a trans man or transmasculine person would not be sexually active with sperm. And I think when we started providing trans care, for me, like 25 years ago, I wasn't thinking about future fertility or the potential for pregnancy. So I just want to make sure we're thinking about that and that we are thoughtful about our language when we talk to folks about their sexual activity. So many of you may have learned in your training, you know, are you sexually active with men, women, or both? Well, that actually doesn't work anymore because in this case, if Sam is sexually active with another man or a cisgender man where there's sperm, Sam has a potential for pregnancy. So I want you to be thoughtful about your language, and I'll give you some guidance and places to find guidance as we move on. Next slide, please. So this is another really important slide because in fact, things have really shifted. As I shared with Sam's experience, many patients, and in fact, many providers have told their patients that testosterone is effective contraception. But we know that trans masculine and gender expansive folks on testosterone, even with no menses, can ovulate, and pregnancies do occur, both unintended and intended. So what contraceptive methods are being used by trans folks, and what do we want to learn today about IUD? Next slide. So we have a couple studies coming or that have already been done, and I'll highlight two. One is Alexis Light and her group in 2018. That was probably one of the first studies that came out that was really helpful for all of us in the field. And that was family planning and contraception use in transgender men. And they found, almost with 200 folks in their study, that 60% had ever used contraception, and that actually there was a higher rate than in the US population generally of 12.7% for IUD. That study was followed by the IBIS group, Moses and et al., and I'm a part of that group. And we just did a large survey collecting our data in 2017 and 18 of almost 1,700 trans and gender expansive persons. And in our study, the numbers were fairly close, but we had a higher IUD rate, a total between both hormonal and copper of 17%. And I just wanted to make sure that folks were aware of the many different reasons that folks will use contraception. And in addition to pregnancy prevention, which is the most common reason, the second most common is avoiding menstrual symptoms, which, as you can imagine, is important for transmasculine folks. If you're interested in seeing more of the research and the publications that have come from that study, there's the link there at the bottom, inclusive sexual reproductive health. Next slide. So I think the take home here as well is that transmasculine and gender expansive folks should be offered the full range of contraceptive options. I think that typically transmasculine folks will prefer a method that does not contain estrogen, but that there is no contraindication to estrogen. Next slide. So in comparing the two different forms of IUD that in the broad categories, next slide, or next link, the copper IUD is unlikely to have bleeding beyond the initial spotting if someone is already not having their menses or not bleeding with testosterone. And it has a longer duration of effectiveness. So if we're counseling folks on which might be the better method, the advantage of the copper IUD, if they're already amenorrheic, is that it lasts for such a long time and you won't get that problem of initial bleeding with the copper IUD that many people experience. If they, however, are not yet on testosterone or just starting testosterone, you might counsel towards a levonorgestrel intrauterine system because the progestin can, or the levonorgestrel can help induce amenorrhea if someone is starting their testosterone. And next slide. This is a more complicated slide that I'm not going to walk through in the interest of time. And I meant to start my little timer. I apologize. How much time do we have, Anita? I meant to start my little clock and I didn't.
We have about 5 minutes, a little bit more.
Oh, and I'm doing okay.
You are. This is wonderful. Thank you.
Yeah. So this goes into a little more detail about IUD selection. So if a patient really does not want any kind of hormone involvement, then their copper T would be your or perhaps potentially their best option. And I've already discussed the issue that there will not be persistent bleeding typically if they're already on testosterone. And as many of you know, the copper IUD is effective for emergency contraception. It's not FDA approved for that, but it is effective. And then if we look at the two levonorgestrel, or the more than two options, but the two dosages, or the regular 52 milligrams and then the lower dose, the 52 milligrams really is, we believe, more effective in terms of supporting amenorrhea. And as you know, FDA approved for painful menses, which would be for many transmasculine folks a goal. The downside of the levonorgestrel approaches is that they're effective for less time. Next slide. So I want to support you all in being thoughtful about your exam and really slowing down when you do, especially a pelvic exam, and develop a process in your intake and with your electronic record to find the patient's own words for their body parts and for experiences. So we want to use less gendered language. So for example, instead of pregnant women, people who experience pregnancy, or people who menstruate, persons who menstruate. It can be hard initially, just as using non-gendered pronouns, they and them, for example, can be very challenging for some people initially. But if you practice, I promise you, you'll get there. You've probably already developed ways for folks to who have previous trauma to be able to tolerate a pelvic exam. Slowing down, I many years ago developed the term verbicane, which using your language to help make a painful experience less painful, and using visualization. If folks have been on testosterone for a long time, there's often atrophy of the vaginal walls, and so pre-treating with vaginal estrogen has been shown to be very well tolerated, meaning there's not systemic effects, and it can make the exam easier. That's also important for a pap smear for trans masculine folks. Check in on what body modifications have been going on, and discussing screenings ahead of time is important. I just want to highlight that most transmasculine folks have had trauma around medical experiences and specifically around exams. Next slide. So if you are, actually, I'll take that back. You may not be aware that you're seeing trans folks, but you probably are. And as I just shared, most people have experienced discrimination and stigma. And so creating safe clinical spaces is critical. Next, you can just click once. There we go. So creating a safe and welcoming environment with signs, gender neutral bathrooms, really working on your intake forms and the language in your forms so that it's inclusive of trans and gender expansive folks. Having exam templates that include all organs so that you don't have to be switching back and forth between a quote unquote cis male or cis female template. It's really important. And then training your entire staff on the sex and gender spectrum. Next. There are lots of resources available, and I'm realizing that, yeah, so these are great links for you to use. Next slide. And I'm going to encourage you to think about the power of language to support inclusion. And in our article called The Imperative for Transgender and Gender Non-Binary Inclusion Beyond Women's Health, we share kind of basically a calling, next click, for you to think about your language. Nope, back up once. Think about your language. When you say women, but you actually mean to include transmasculine folks, think about what language would actually bring all folks with all genders to your clinics to feel safe. Next slide. So these are the key points. IUDs can be a well-accepted birth control option. The levonorgestrel intrauterine system can support undesired bleeding. And really remember the key points about shared decision-making around IUD and contraception in general. Elicit what are the patient's concerns and needs, and approach both your history and your physical exam in a trauma-informed manner that would then include a less gendered language. And think about your clinical setting. Is it really welcoming to a person who's trans and gender expansive? Next slide will probably be a thank you. Suzanne Goodman, thank you much for your some of your support here, and UCSF, Bixby Beyond the Pill. And I want to just highlight, it's a little bit, next slide, because I just want to highlight the resources. So these are extremely helpful. I'm going to point you first to Kapansky, which is really helpful. I mentioned language. So there's some really wonderful resources in that article, Contraception Across the Transmasculine Spectrum. In addition, the article that I mentioned on the imperative for transgender and gender non-binary inclusion also has a lot of resources for you to think about how you change your sexual history and exam. Thanks so much.
Thank you, Jen. This is Rachel. I just want to say that we will put all of those links up on the website when we post the video.
Thank you.
Excellent. Well, thank you so very much. Really inspiring. Our last speaker today is going to be Dr. Paula Bednarket, and she is Associate Professor of Obstetrics and Gynecology at Oregon Health and Science University and Medical Director of Planned Parenthood Columbia-Willamette, based in Portland, Oregon. She's been on the forefront of research for reproductive care services with a real strong emphasis on pain control during gynecologic and reproductive health care services and procedures. She's been very active in expanding services via telemedicine and for providing IUDs following abortion, which is clearly why we've asked her today to talk to us about IUD use following abortion care. And please, again, feel free to submit your questions during the talks. We want to move directly to that Q&A session right after the end of this Dr. Bednarket's talk. Thank you.
Hi, thanks so much for inviting me to present about IUD use following abortion care. Next slide. These are our objectives: to discuss reasons to offer immediate IUD insertion following abortion, to review safety and effectiveness data about immediate IUD insertion, and to discuss procedure preparation and technique. Next slide. So why offer immediate IUD insertion? We know that unintended pregnancy and abortion are common. In the United States, 1 in 3 women will undergo an abortion in their lifetime. It's important to discuss short and long-term personal reproductive goals with each patient. Even women who may have had an abortion for a fetal anomaly or may have been planning to continue but had a miscarriage may not want to get pregnant again soon. For those who are interested in an IUD after a first trimester aspiration or a second trimester D&E, we want to think about the best way to offer it. We know that fertility returns very quickly. Ovulation can occur as early as 8 to 10 days after an abortion. And we know that many women resume sexual activity within days or weeks after. Asking them to return for a separate visit can create a real barrier. So immediate IUD placement on the same day as the procedure can have important advantages, especially reducing time and travel needed for an extra visit. Also potentially reducing pain, and it can be less with immediate IUD insertion. The cervical os is open and patients are usually pre-medicated for pain control with the abortion procedure or even asleep. One RCT by Homan et al. Actually collected pain data to directly compare between immediate versus delayed insertion and showed significantly lower pain on a VAS with the immediate group compared to delayed insertion. And studies that have evaluated satisfaction show high patient satisfaction when immediate IUD insertion is offered. Next slide. One of the key outcomes that we measure when we look at contraception is continuation or ongoing use. Continuation for an IUD depends on first receiving it, step one, and then whether there's an expulsion or removal. Next slide. An initial hesitation about providing immediate IUD insertion routinely was that the expulsion risk may be too high to be worth it. Expulsion rates vary among historical studies, so I'll focus on data for the T-shaped IUDs that we mostly use now. These are studies that looked at immediate IUD placement following first trimester surgical abortion. In a previous presentation, I spoke about the PAIR trial that randomized 578 women to immediate versus delayed IUD insertion after first trimester aspiration. That study found the expulsion risk of 5% in the immediate group and 2.7% in the delayed group at 6 months. Dry et al. Reported data for a cohort of 256 women who underwent immediate IUD insertion, and 123 were in the first trimester and had a 0.8% expulsion at follow-up, which was about 8 weeks for that group. Fox et al. Published a retrospective review of 308 patients, 212 of which were post first trimester abortion. And there was a 3.1 expulsion at follow-up on average, which was about 5 months after the procedure. And I've also included expulsion data from a large study that randomized women to receive a Nova-T versus a levonorgestrel IUS. It was conducted in Scandinavia and Hungary and included 509 women who received IUD placement immediately after a first trimester surgical abortion. And then about over 2,000 women who had interval insertion. And this here is the first year follow-up data that was published in 1987 and has comparative outcomes for immediate and the interval insertions. And the data is separated out by the IUD type, but it's similar between IUD types, about 8% immediately after the first trimester abortion and 3% for interval insertion. Next click. For second trimester expulsion data, there are 2 key RCTs that randomized women to immediate versus delayed IUD insertion after second trimester D&E. Kramer et al. Published a trial that randomized 215 women undergoing D&E at 12 to 24 weeks to immediate versus delayed insertion of a copper T380. Of the 71 women randomized to immediate IUD insertion, 7 didn't receive their IUD, 5 changed their mind after randomization, and 2 had heavy bleeding after their D&E. There were 2 expulsions among the remaining 64 who did receive immediate IUD insertion, so it was 3.1% in the D&E group. And in the delayed group, only 26 of the 88 subjects that had follow-up data returned to receive an IUD. There were no expulsions in that group. Homan et al. Enrolled 93 women undergoing D&E at 15 to 23 weeks. 100% of subjects randomized to immediate insertion received their IUD, and 3 women, or 6.8%, had an expulsion. Only 45% of subjects randomized to delayed insertion returned to receive their IUD. 1 woman out of 20 who received the delayed IUD had an expulsion, or 5%. Dry reported an expulsion risk of 3% among 133 DNA patients, and Fox 7.4% among 96 DNA patients. And I'll also mention the Contraceptive Choice Project included about 830 women who had immediate post-abortion IUD insertion, and they reported combined first and second trimester expulsion outcome and reported 6.6% at 6 months. Next slide. Although there's little data to guide us on optimal techniques for immediate IUD insertion, this is a key interest for clinicians to minimize the risk of expulsion. In the post-abortion setting, we'll already have done a bimanual exam and evaluation of the cervix. And after the abortion is confirmed to have no complications and to be complete, the IUD can then be placed. So uterine cavity size is assessed, usually not using a traditional uterine sound. Many clinicians use a more blunt instrument that's readily available, like the suction cannula or the IUD inserter itself. After first trimester abortion, most clinicians use the manufacturer-provided inserter. Next click. Sometimes the inserter may be grasped with a ring forceps to guide past irregularities in the uterine contour to reach the fundus. Next click. In the second trimester, frequently the inserter can also be used, but if the inserter is not long enough to reach the fundus, then the IUD may be removed and the inserter and the IUD can be placed using a ring forceps, similar to immediate postpartum placement technique. So there's no direct comparison data about ultrasound. Ultrasound is a question that we commonly get, and there's no direct data about whether it's important to use an ultrasound or not. However, earlier studies in the 1980s of immediate IUD insertion following second trimester abortion reported much higher expulsion rates and at the time that was deemed unacceptably high. So techniques described in the studies by Dry and Fox reported lower expulsion rates using ultrasound guidance for placement. Ultrasound guidance was also used in the Homan RCT and for some of the patients in the Kramer RCT, and both reported much lower expulsion rates than previously published. Using ultrasound guidance during second trimester D&E has been shown to decrease complications, especially in training situations. So it's often readily available when performing a D&E. And when US abortion providers were surveyed about technique, ultrasound guidance was reported to be commonly used for immediate post-abortion IUD placement. Next slide. So moving on to continuation. Consistently, there's higher continuation with immediate IUD insertion, both after first and second trimester surgical abortion. Focusing on the RCT data, in the paired trial, 92% in the immediate group and 76% in the delayed group were using an IUD at 6 months. And you can see the higher continuation rates for both Homan and Kramer as well. In Kramer specifically, the trial, there was 82% in the immediate group and only 28% in the delayed group were using an IUD at 6 months. One of the limitations of all the studies that follow patients following abortion care is a high loss to follow-up, often more than 30%. Follow-up after abortion care can be difficult. People travel far, and there are many other reasons that it might be difficult for them to follow up, not only for study purposes, but also in providing clinical care. Next slide. Published studies haven't been powered to assess future unintended pregnancy, but this is obviously one of the most important questions when we provide contraceptive options. This is a meta-analysis from the Cochrane Review published in 2014 that shows unintended pregnancy at 6 months is lower with immediate IUD placement compared to delayed. Goodman et al. Also they had a retrospective study published in 2008 that found lower repeat abortion with immediate compared to delayed insertion. Again, despite knowing the increased risk of expulsion that we've reviewed, the increase in continuation is because just receiving the IUD in the first place is so much higher when we have the option of immediate insertion. And then once you're able to receive the IUD, then you can continue using it and prevent pregnancy. Mathematical modeling by Reeves et al. Estimated that moving from delayed to immediate insertion could prevent over 70,000 unintended pregnancies annually in the United States. Next slide.
4-minute warning. 4-minute warning.
Infection is another important safety outcome to evaluate. Perioperative antibiotics are recommended at the time, let's see, next slide. Perioperative antibiotics are recommended at the time of first and second trimester surgical abortion by multiple guidelines, including the WHO, Society of Family Planning, and ACOG. Next slide. Upper genital tract infection is rare following abortion or IUD insertion. So again, many studies weren't powered to evaluate this outcome. This is an analysis from the Cochrane Review that shows no difference in PID risk between immediate or delayed insertion, and observational studies corroborated this. Therefore, there's no need to change the antibiotics that we offer. Yeah, you can go on to the next slide. In terms of screening, screening can take place at the time of IUD placement, and there's no need to wait for the results prior to placing the IUD. In the interest of time, I won't go through the data, but you can see here that the only contraindication to placing an IUD is really direct purulence on exam. Otherwise, it's category 1 or 2. And if the screen result returns positive, then the patient should be treated with appropriate antibiotics. The IUD doesn't need to be removed unless the patient develops symptoms of concern. Next slide. Perforation is another key safety outcome. For post-immediate IUD insertion, there were no IUD perforation reports among any of the RCTs or observational studies. Next slide. The only absolute contraindication listed in the CDC MEC for immediate IUD insertion is septic abortion. Fortunately, complications are rare, but if there's hemorrhage or uterine perforation during the abortion procedure, most providers would not place the IUD at that time. Instead, we'd offer alternative methods and place the IUD once the complication has resolved. Next slide. And also to briefly discuss medical abortion. The proportion of medical abortion varies among countries. In the United States, it's approximately 20 to 30% of all abortions, while it's higher in Europe in general and highest in Sweden and Finland, where medication abortion is over 90% of all abortions. Next click. After first trimester medical abortion, patients need to return for a follow-up visit. The abortion needs to be deemed complete, and then the IUD can be placed using interval technique. Data about early IUD placement following first trimester medical abortion has been reported as early as 3 days after misoprostol. Most studies have compared IUD insertion with 1 to 2 weeks being considered early compared to 3 to 4 weeks after medications. And no significant differences were reported between early or late placement in expulsion or perforation. Some studies have shown increased continuation with early placement, and others have shown no significant difference, possibly since there's already an extra visit that's needed following first trimester medical abortion. So generally, once the abortion has been deemed complete, the IUD can be placed when the patient is present to prevent the need for yet another visit. Next click. There's less data for second trimester medication abortion, but clinically it's more similar to immediate postpartum IUD insertion. A recent study published in February 2021 that was performed in South Africa randomized 114 women to immediate or delayed IUD insertion after medical abortion at 17 to 20 weeks. Of the women who had immediate IUD insertion, 32% had either expulsion or removal compared to 7% in the delayed arm. And despite this difference, 56% of women in the immediate arm were using an IUD at 6 months compared to only 19% in the delayed group. Next slide. In conclusion, patient-centered contraceptive provision is an important part of abortion care. Immediate IUD insertion following abortion is safe in both the first and second trimesters. Providing patients with immediate IUD insertion decreases barriers to access, increases contraceptive continuation despite a higher expulsion risk, and decreases unintended pregnancy and repeat abortion. Thanks very much.
Thank you so very much. That was wonderful. And we have time for a few questions. I'm going to invite you all, please, to look at the chat room because there's been some wonderful discussions of questions and answers there. Jen, thank you for putting in some of your answers to those really great questions. Quickly, Stephanie, how is it, what type of support or training do you think might be necessary for staff? And is there any evidence that counseling training does make a difference for adolescents care?
Yeah, thanks, Anita. So most of the published literature on counseling adolescents about IUDs actually is about did you or did you not tell adolescents that an IUD was an option, rather than really, so it's like, oh, do pediatricians tell people about IUDs? Do family docs tell people? But that's different from learning how to counsel. I want to put out a shout out for a book that was published in 2019. I am neither an editor nor a chapter author, called Optimizing IUD Delivery for Adolescents and Young Adults. I can give Rachel the link. It's put out by Springer, and Mandy Coles, who's a pediatrician, is the principal editor of that book. And it actually, that book does actually have a lot of chapters about how to talk to adolescents and how to optimize adolescent IUD care.
That's absolutely wonderful. There was a question for some more elaboration on the use of ring forceps and stabilizing the inserter tube for placement. I think that was Paul. You discussed that, didn't you?
I'm not sure what the question is, but you mean how to do it? There are, yeah, there are probably some drawings or things that might be helpful, but in general, holding the ring forcep a little at an angle so that the IUD, the inserter, or the IUD itself can be straight, placing it to the fundus, opening, and then making sure you sweep to the side so that you're not in any way dislodging the IUD. If you're using the inserter, same thing, holding it, placing it to the fundus, removing the ring, knowing that you've made it to the fundus, and then you can place the IUD using the inserter if you choose that. Most people who use the ring technique would take the IUD out of the inserter and place it directly using the ring forceps.
Now, the problem with that, you've got to be careful that you don't clamp it down and destroy the releasing membrane, right? It has to be very gentle.
Right, that's true. You don't want to clamp it down, especially so with the levonorgestrel IUS, the hormone releasing portion is along the stem, and you place the ring right at the top of the T of the IUD. And yeah, you don't want to click down and really decompress the IUD.
Excellent. Okay, well, we're just right on time. Again, some of you put in questions that we had a nice little discussion. Please, we can capture the chat and post that too if people would like us to do that. But I want to thank you all for your wonderful participation, giving us these wonderful insights to just so many issues that nobody would have thought of 30 years ago when we were first talking about it, but really deserve to be front issues, page issues now. And I want to return the conference back to Rachel for the next session. Thank you all.
And I would like to invite our next moderator, Lisa Haddad, to step up and lead the second session.
Great, thank you, Rachel. I hope you can all hear me. The next session I'm really excited to have you all take part of is about access to IUDs, real life challenges to bringing evidence to policies and practice. And this is a shift from many of the prior sessions that have focused quite a bit on the evidence base and the benefits or the clinical challenges with IUDs. And this is really focusing on what is the current practice and policies that impact access. And I'm really excited to have amazing panelists with us today and that bring the clinical research and policy expertise to enable us to have a broad perspective of health policy and implications that influence contraceptive access and care. Each of the panelists will introduce themselves and highlight some of their perspective along with some of the data on the topic and talk for about 8 to 10 minutes each. And the bulk of the session will be spent in hopefully an active dialogue. So I encourage all of you to paste your questions into the chat and we'll hopefully be able to bring some of these up in conversation because again, I think a lot of us are a little tired of long presentations. And so our hope is that we can have some active engagement from all of you in the discussion as well. So I'm going to pass along to Michelle Moniz, who's going to start off and looking forward to a great session. Thanks.
Thank you. I'm really excited to kick this off. Thank you for having me. Next slide, please, Rachel. So I and the other panelists are going to start just by sharing a little bit about ourselves and the research that we do and some of the key takeaways from that research in hopes that we can build a very robust foundation for a rigorous discussion to follow. So I am a generalist obstetrician gynecologist. I work at the University of Michigan and have the real privilege of taking care of women across the lifespan. I'm also active in quality improvement projects at the state level and on committees nationally. And my training is in health services research and implementation science. Next slide, please. For those who may not be as familiar with health services research or implementation science, you can think of it as on the opposite end of the research spectrum from basic science or bench work. And so the goal of health services research is to determine how people access care, what they pay out of pocket for that care, and what happens to people as a result of that care. Implementation science is focused on studying strategies that can help us get evidence into regular use by policymakers and practitioners. So when we have randomized controlled trial data, systematic review, and meta-analysis data, how do we make sure that that data is actually changing care delivery at the front lines? Next slide, please. So broadly, my work in the health services research space is really focused on women's utilization of contraceptive care and out-of-pocket spending for those services. I have evaluated the effects of the Affordable Care Act's preventive services provision. This provision newly required commercial health insurance plans to provide first dollar coverage for preventive services, including contraception. And what I mean by that is these services they had to be covered without copays, deductibles, or coinsurance. We've also looked at the effects of Medicaid expansion under the Affordable Care Act on women's access to family planning services. Next slide, please. In the implementation research realm, I've looked at a variety of different aspects of immediate postpartum LARC care delivery. We've done some qualitative work looking at Medicaid payment policies for this service. So in the United States, Medicaid is our health insurance program for folks living on lower incomes. And maternity care in the United States is often paid with a bundled or a global reimbursement package. And so these Medicaid policies refer to a practice when a state Medicaid agency kind of pulls out the LARC payment from that bundle and provides an additional reimbursement for that service to avoid a financial disincentive from offering that care. We've also done a qualitative study looking at 11 hospitals across the country and trying to understand how they were able to launch immediate postpartum LARC services. What were the barriers and facilitators to that? What were the strategies they used? And what were the costs of those efforts? And we are currently conducting a prospective evaluation of multi-component implementation strategies to embed this care into routine clinical practice. Next slide, please. So what have we found from this work? Related to the recent US healthcare policy changes affecting coverage for LARC, the take-home message is that we've seen reduced cost sharing and increased LARC use. So there are a few studies demonstrating that Medicaid expansion in particular has improved access to family planning care. We've also seen a clear reduction in cost sharing for services. So individuals are paying less out of pocket for contraceptive care. And among those who had out-of-pocket costs before the ACA was passed and their out-of-pocket costs then dropped to zero, it's clear that there has been increased LARC use in that group. And we've also seen that these policies have been associated with reductions in income-related disparities and unintended birth rates, suggesting that when we implement policies that reduce out-of-pocket spending for contraception, we may be better enabling folks to initiate their preferred method and to prevent pregnancy if that is their preference. Next slide, please. However, we know that policy change isn't always implemented as intended. Sometimes additional tweaks are needed. And in fact, 12 states across the country have not yet adopted Medicaid expansion. So individuals living in those countries are not reaping the benefits I've just described. We've also demonstrated that not everybody is benefiting equally from these policy changes. So one example is that postpartum individuals still seem to be experiencing cost sharing for contraceptive care. In one of our analyses looking at a national sample of commercially insured women, we found that 1 in 4 continue to pay out of pocket for postpartum IUDs and implants. The median costs for these services are relatively affordable, around $25, but there's a wide range in costs, with some women exposed to cost sharing of $2,000 or $3,000 to obtain one of these devices. We've also found that LARC use seems to be relatively uncommon among commercially insured women compared to other groups of women of reproductive age, and that cost may be a modifiable barrier in this group. We found that postpartum LARC use was lower among those that had higher out-of-pocket spending. Next slide, please. We also know that even when policies are implemented as they are intended, that it may not always translate into changes in clinical care delivery. So immediate postpartum LARC provides a really good example of this. I mentioned that Medicaid agencies across the country are adopting changes in reimbursement policy for immediate postpartum LARC. And in fact, since 2014, 43 different Medicaid agencies have adopted this kind of payment policy. And we have evidence from multiple states that suggests this has not, in fact, translated into rapid adoption of these services at the hospital level. So Iowa and Louisiana provide data from 1 year out from their policy changes, suggesting that LARC utilization among Medicaid enrollees in these states remained quite low, and that only one academic center was offering these services in each of these states 1 year after policy change. South Carolina gives us a bit of a longer view. At 5 years out from Medicaid policy change, utilization among Medicaid enrollees was 5.7%. But again, less than half of hospitals in the state were offering these services. Next slide, please. So why might that be? Well, one of our studies looked at hospitals that successfully launched these services. And what you can see here is a long list of conditions that had to be in place for hospitals to be able to launch these programs. Champions were critically important. There also had to be an enabling financial environment with reimbursement from major payers or hospital leadership that were willing to take a bit of a financial loss in order to offer this recommended care. There are multiple other conditions documented here that also helped the process along, but you can see it's a lot of conditions that have to be in place to launch this service. And in fact, we found that because of this, it took on average 18 discrete implementation strategies to be able to launch this care with a range of 11 to 22 different strategies. These were often executed by implementation champions. Next slide, please. One of the key takeaways of this research is that these clinical champions are the linchpins that are kind of executing these strategies, really moving forward these different initiatives. And I've listed 6 characteristics on this slide that are important for these change agents on the ground to be effective. A lot of the prior work on quality improvement champions has looked at what these champions do. And this research really newly uncovered who they are is as important as what they do. And these are these 6 key characteristics that we want to try to grow in people who are leading our change efforts to drive quality improvement in contraceptive care delivery. Next slide, please. The last major takeaway I want to mention from our work is that patient preferences must be at the center of these quality improvement processes. We've seen in multiple ways that there's a real tension between efforts to enhance contraceptive access and a risk of non-patient-centered care. There are multiple qualitative studies emerging about immediate postpartum LARC with individuals who are counseled about this option or utilize this option for care, suggesting that many individuals felt like they had insufficient information to make an informed decision. They felt pressured to choose a LARC option when they felt this didn't actually align with their preferences, and they may have later faced barriers to LARC removal. We are finding similar evidence in some of our ongoing work in progress where we are measuring the patient experience of care as an indicator of quality provided at our own institution. Next slide, please. And these findings really I think are a call to action to our entire community. Some of the things that we are instituting locally, we are trying to involve patients and communities in designing our quality improvement efforts and our LARC access initiatives. We are also working to establish institutional safeguards that promote shared decision-making. And we are really just trying to be quite vigilant. I mentioned that we are measuring the patient experience of care. We will also look at rates of contraceptive counseling in the prenatal setting to make sure that individuals are being given time to really consider their different options, as well as looking at method utilization and other indicators of the quality of contraceptive care in the peripartum setting. We are really looking to build opportunities for institutional and personal self-reflection about the biases we all bring to the table when we are offering care and thinking about how to make sure those biases don't affect care delivery and to really keep patients' preferences at the center of the work that we do. Next slide, please. So my takeaways for you are that policy change is often a necessary first step to implement evidence-based practices, but course corrections may be needed and policy change alone may not be enough because clinical practice change is so very complex. I think we often falsely believe if WHO or CDC or ACOG release guidelines that will translate into clinical practice change, and often much more intentional work is needed. And lastly, that there's urgent need to center patient preferences in the work that we do to enhance access to LARC methods. So thank you for your time. And I really look forward to our conversation and Q&A session after the other panelists present.
Thank you, Michelle.
great.
Sorry.
Alina, I was going to introduce you, but go ahead.
Oh, thank you. That's fine. Hi, I'm Alina Solganikoff. Next slide, please. Unlike many of the other presenters today, I am a policy researcher. I am a Senior Vice President and Director of Women's Health Policy at the Kaiser Family Foundation. We are a nonprofit that conducts nonpartisan policy analysis and journalism and polling on US-based health issues. And just to be clear, we are not affiliated with Kaiser Permanente. The focus of the research that we conduct in our women's health group really focuses on health policies of importance to women throughout their lifespans. We have an emphasis on coverage, affordability, and access to challenges facing underserved women. Those are women who are, in many cases, uninsured, women of color, and sometimes women who are publicly insured or low-income women. And I sit at the table at numerous kind of federal, state, and nonprofit advisory committees, really trying to bring a lens of what policy means to practice, particularly looking at financing care. And I was involved with the Women's Preventive Services recommendation in the past that Michelle Moniz spoke about, and continue to be involved on in advisory capacity on the Women's Preventive Services Initiative today that's still making recommendations for the Affordable Care Act. Next slide, please. So today what I'd like to do is share with you some insights from two surveys that we recently conducted in 2020. One is a survey of OBGYNs that we launched last March, not knowing that we were basically heading into a pandemic. We have a sample of 1,610 OBGYNs that are currently in clinical practice, and we launched that from March to September. We also did a survey of women. These are individuals who identify as women. And that was through the NORC, the NORC, University of Chicago AmeriSpeak panel, and that represents 3,661 women, and that was done in November and December of 2021. What I want to touch on a little bit is what we learned about what providers offer, whether women are getting the methods that they prefer, harkening back to the points that Michelle Moniz had made, and also a little bit about the future of contraception. What does that shift mean, particularly from clinical settings, and what does that mean for IUDs? And how can we do better at giving women choices and access? Next slide, please. So, we had a lot of presentations in the first session as well about getting into clinical, once people are in clinical care. But I think it's important to remember that not everybody has actually been to see an OBGYN or a nurse practitioner, especially younger women. We had a presentation about adolescents. You see here, 30% of those 18 to 25-year-olds have never been. And even if you look at 3 or more years, you can see about 1/4 of women of reproductive age has been at least 3 years, and sometimes never. And the other thing that I really want to highlight for you, and this is again a US-based lens here, but among uninsured women, where really the access or utilization rates are considerably lower than those who are in private insurance. And about half say that it's been 3 or more years, or that they have never been to an OBGYN. The rates are higher among those with Medicaid. Again, in the United States, insurance matters, and we see this over and over in our data. Next slide, please. The other thing that I think it's important for us to always remember is that contraceptive preferences shift over reproductive lifespan. I'm sure that's not at all news to you, but among younger women, we see a much higher preference of oral contraceptives, increasing but still lower rates of IUD use. But that number really, nearly doubles when we look at women who are 26 to 35, and then among those who are in the older age group of 36 to 49. Next slide, please. The other thing that I think is important for us to recognize is where women get their care, because a lot of the policies that we have really shape how that care is provided and what providers can offer. Overall, the vast majority of women say that they get their OBGYN care, their contraceptive care at a doctor's office. A smaller share, 13%, said they got it at a clinic. That's either a family planning clinic or a federally qualified health center. But you can see here there are significant differences here by race and ethnicity, with Black and Hispanic women having significantly higher reliance on clinics compared to white women, but still a significant share using doctors' offices. Next slide, please. And when we asked OBGYNs about some of the practices around IUDs, and I encourage you to check out this report, which has a lot of terrific information. I'm just going to give you just a little bit today. We see that those who work in health centers are more likely, higher share, say that they stock IUDs on site, and that a higher share provides same-day placement. This is also, higher in larger. These policies are also more commonly found in large and medium practices compared to those who are in small practices. Next slide, please. But one of the findings that we had from the Women's Health Survey that really kind of surprised us is the high share of women who say that they are not using their preferred method of contraception. Over 1 in 4 uninsured women, 1 in 5 women on Medicaid, and 1/4 of low-income women said that they are not using their preferred method. Next slide, please. And when we asked them why, 1/4 said because they can't afford it. But interestingly, and I think importantly, particularly with this audience, 20% said that the provider recommended a different method, and that was the method they were using. So again, the patient's preferred method was not fully considered. You'll see here that a sizable share here say other. This is when we asked, this was an open-ended question, and when we asked that, we got responses that they said they couldn't use their preferred method because they were breastfeeding, or a number of women said that their partner was unable to get a vasectomy, and some said that it was because of the pandemic. Others said that there were accessibility reasons, such as they couldn't get an appointment or they couldn't get to a doctor's office. And again, this is an area where telecontraception or telemedicine could make a difference for these women. Next slide, please. We were also very interested in looking at the quality of care that women were receiving when they got their contraceptive care visits, and we were really pleased to be able to use the newly endorsed NQF measure of person-centered contraceptive counseling on our survey. This was developed by Christine Dellendorf and her colleagues at UCSF. And this is looks at 4 items of contraceptive counseling using a 5-point Likert scale, with responses ranging from 1 for poor to 5 for excellent. The items include questions such as respecting me as a person, letting me say what mattered most to me about my birth control, taking my preferences about my birth control seriously, and giving me enough information to make the best decision about my birth control. As you can see here, only 44% of reproductive age contraceptive users gave all of these excellent reviews, but you can see here that we have pretty sizable differences by race and ethnicity, with Black and Hispanic women showing lower rates of excellent care. Next slide, please. One of the other opportunities we had, because we were able to survey women during the pandemic, is around telehealth care. And you can see here, before the pandemic really got into full swing, just only a small share of women said that they had used telehealth visits. But you can see here that after a few months afterwards, you could see that those numbers had really spiked. But I did want to flag that uninsured women, still 20%, so their utilization rates were still considerably lower. Next slide. We were also able to ask OBGYNs about their practices in telehealth, and this was really interesting in terms of seeing a kind of a mirror image. Prior to March 1st, very few practices were actually using telehealth. 12% said that they were, and after, by June, 84% said that they were using telehealth. So they used it for a range of different services, which are detailed in the report. But that number continues to be quite high. And I think a lot of the payment issues will determine whether OBGYNs will continue to use telehealth as a meaningful part of their practice. Next slide, please. But we did find overall that very high rates of satisfaction for telehealth. This reviews mental health, chronic care, management, COVID, and on the bottom, I think, which is the closest to an OBGYN visit, which is an annual checkup or a well woman visit. You can see here, though, that the share of women who rated it as excellent was 1/4 was lower than the rates for mental health services, so that it may not always lend itself to the services that women will need. Next slide, please. And then just before I close, I just think it's important for us to recognize the context of care. While we found still very few women, about 4%, are getting care through telecontraception apps, these numbers are growing. There are many, many apps. They provide hormonal contraceptive methods, in some cases STI testing, and some of these companies are small, but some of these are quite large and quite highly valuated these days. So the other thing I think it's important to recognize is that these services are generally not providing women with contraceptive counseling. Many of them are fundamentally a mail order service for contraception. Some do a little more, some do a little less, and very few actually do direct referral to bricks and mortar for women who might want an IUD. And then next slide. And then just kind of a little bit looking to the future, when we asked women about their preferences and comfort with pharmacy access, with pharmacists prescribing birth control, which many can do in several states across the country, we do see that there is generally pretty high support, but a lot of differences by race, ethnicity here that I think are going to be important to consider as we look to expanding non-clinical access to contraceptive methods. Similarly, as we're looking at OTC potentially access for birth control pills, you can see here that there are some real differences, and in some cases, we'll have to, if that actually happens, we'll have to work with not only some of the payment issues and coverage issues, but also how we make sure that the patients are feeling that they're getting the care that they're the most comfortable with and provides the highest level of care for them. So with that, I'm going to turn it over to, I don't know, to Lisa or to Christina.
I'll pass along to Christina. Christina, are you there?
I'm here. Thank you very much. Thanks for inviting me. It's I'm just sad that I can't see you in real life. I guess I have to be happy that I won't have to suffer from jet lag afterwards. But I will, yeah, next slide, please. So I'm from Sweden, Karolinska Institute, head of Department of Women's and Children's Health, and gynecologist, so I work at the University Hospital in Stockholm. I'm also the director of a WHO collaborating center for research in human reproduction. So this center is part of the WHO special program that was started in 1972. And one idea with this with the collaborating centers was to have academic units in the clinical environment to be able to implement research findings. And I think that has been extremely important. So our research is from bench. So we have an experimental research wet lab to bed, that's the clinical trials, and then to the hands of women, and I use women inclusive. So that's the implementation globally. I'm also very proud to have been a member of the International Committee for Contraceptive Research at POP Council. Again, that was also, the idea was to facilitate translational research with basic research and clinical research. Well, I will bring a European and Swedish perspective. I'm the former president of the European Society for Contraception and Reproductive Health, and we have a challenge in Europe because we have a huge language barrier. There are so many different languages. Each country has their own guidelines, and then in the national language. Yeah, and so I'm involved with guidelines work with the WHO, with FIGO. I'm also heading one of the FIGO committees on human rights, refugees, and violence against women. So I will give a few examples adding to what we've already heard. If I can get the next slide, please. So as we know, and we've had great examples now on LARCs and IUDs being the most effective methods, as we know, and also with the highest user satisfaction and continuation rates. And I think that's continuously shown from the old WHO studies looking at compliance with different methods to more updated studies now, and fantastic choice study from the States. And we also know from various surveys, we heard about some surveys now, we have Swedish surveys performed 2013, 2017, and we're just about to repeat it now. And from that, we also know that women want contraceptive method which is highly effective. So effectiveness is high on the wish list, as well as few side effects. So it should be effective, safe, with few side effects. And of course, that's very contradictory if we look at the usage. And in Europe, it's very clear that it's still the COC, which is the dominant method, and percentage LARC use and IUD use is much lower, and especially among younger women. And this is despite all our updated policies and guidelines and so on. Next slide, please. So in Sweden, we shifted from focus on perfect efficacy, Pearl Index, to typical effectiveness. And that was actually surprisingly difficult because the regulatory agency was, it was quite a struggle actually to get acceptance for this. But I think it has been important, and I think that's work that remains to be done in other places in Europe also. We updated guidelines. I mean, it's since long we've had the evidence on IUDs being also a good first choice among no-libs. But still, it has taken so long, and we know there are still guidelines where IUDs are actually not recommended for no-libs, and still so frequently in the clinic that I have patients who come and say, but yeah, but I can't use it, or parents who say, but it can't be used. And even healthcare providers, but that's rare, at least in Sweden nowadays. So we also trained healthcare providers, and in Sweden, it's midwives and gynecologists who provide contraceptive counseling and prescription. And we also, and that's done in youth clinics, in abortion clinics, and in midwifery clinics, and then by some gynecologists. But most of healthy women are seen by midwives. We have increased reimbursement because we know that that affects choice and uptake. So it's reimbursed up to 26 years. And we also stress the added health benefits. So this is something that's done in many places. And we saw a small increase in IUD uptake. But then in addition to this, we got the new LNG IUD options. And that actually, so I think it's interesting that sometimes, despite that we do all these things, very little happened. But what catched attention was this new option, and that also got media attention and social media attention. So if we go to the next slide, here you can see what happened immediately after the launch of the first low-dose LNG IUD. So traditionally, it's been after birth of the first child that women have chosen a 52 milligram LNG IUD. And the mean age for the first child in Europe is 29. Now, after the launch of the low-dose LNG IUD, you can see that the uptake among younger women increased dramatically. And that also led to an increase in provision of LNG 52 milligram LNG IUD. And we could also see that unplanned pregnancy abortion rate went down. And for the first time, we also got a shift. So the highest rate of abortions are now between 25 and 35. So next slide. Yeah, so then if we turn to the impact of counseling, we heard a little bit and our various models, but there is actually no consistent recommendation on how to provide effective contraceptive counseling without bias and coercion. And also, I mean, there have been various strategies to improve uptake of LARC, but which has failed when it comes to unintended pregnancy following an abortion. So next slide. So just a few words on a trial that we just conducted. It's called the LOVE trial. You can pronounce it LOVE, and it's obvious that it stands for LARC Forward Counseling. And we wanted to evaluate the effect of structured contraceptive counseling on uptake of LARC in a real-life setting. So it was only the counseling model that was the intervention. So we maintained everything else like cost, access, and so on. And then we also wanted to look at pregnancy rates. And uptake was defined as choice and initiation. Next slide. So just briefly, I won't go into the details of but it was a cluster randomized trial, a large trial. We had 1 year follow-up after inclusion. It was done in all the clinics that provide contraceptive counseling. So intervention clinics received training in how to use the counseling model, and control clinics maintained their routine counseling. And inclusion criteria were sexually active women or people above 18 and without wish for pregnancy seeking contraceptive counseling. So next slide. And this is the intervention package. So it was a 7-minute educational video that participants could watch prior to the counseling. So in the waiting room, an effectiveness chart focusing on typical use effectiveness, and also indicating failure rate per 1,000 women instead of 100. A demo box, and then key questions intended to make the participant reflect about how they would deal with a pregnancy if it were to occur at the moment, for how long contraception would be needed, and also to describe menstrual bleeding patterns and pain. So very simple, and I mean, components that are already used, so that the thing was to use this in a structured way, and all components. Next slide. And this intervention, the use of the structured counseling resulted in a high uptake of LARCs, fewer pregnancies among those recruited at abortion clinics, overall fewer pregnancies, but post-abortion it was significant at the 12-month follow-up. A high satisfaction among participants and also among the healthcare providers, and either neutral or time saving. So overall, success. Next slide. So the next thing to reflect a little bit on is implementation on telemedical abortion. So this was the first publication on telemedicine abortion from Women on Waves. And I mean, at that time, this was a little bit of a scandal, I would say. So it was met with skepticism, to say the least, and it absolutely didn't make its way into guidelines at that time. So it's interesting to see, since then, this was 2008, now we have guidelines, we have WHO guidelines, we have FIGO recommendations, and so on. Next slide. And we also heard about post-abortion LARC provision. I mean, we still have national guidelines in Europe and elsewhere recommending to wait even after surgical abortion and not to insert an IUD immediately after surgical abortion. We have managed to implement, I think, in most places, the quick start with implants after medical abortion, and also early insertion placement of IUDs that we just heard after medical abortion. Next slide, please. But so now, in response to COVID, we can see what we also heard in the previous presentation, that countries have taken different approaches, and we can really see in Europe that this is ranging from imposing increased restrictions to actually removing barriers. And so we have in some countries, like in UK, where home use of misoprostol was not possible 2 years ago, suddenly 80% of abortion provision is by telemedicine. So this has changed provision a lot. But I think it will be very important now, and that's something I really hope that we will be able to discuss, how we can ensure access to post-abortion contraception in telemedical abortion, especially to LARC provision, and also, of course, LARC provision in telemedical contraceptive counseling. Next slide, please. Thank you. And over to Lisa.
Great, thanks. Rachel, can you take off the presentation so we can see all the speakers? Is that possible? Great, thank you. I appreciate everyone's presentations. I learned quite a bit. I want to jump right into some of the discussion. So in your answers for each of these discussion questions, if you can particularly pay attention to some of the reproductive justice or equity aspects as you phrase some of your responses, I think those are important for us to consider. And when possible, also trying to anchor some of your answers in thinking more broadly outside of the US setting as well, if possible. So what are some of the key considerations or real world challenges to making methods, specifically IUDs, available? And what are your thoughts on how we can begin to address it? And many of these things were covered in some of your talks, but The chat also has brought up some particularly interesting items that I think were not covered. So Alina, one of the things that were brought up in the chat particularly was about religious affiliations in clinical care settings and how that may in itself be a barrier or to evidence-based policy changes in clinical care. So are there any sorts of ways that we may be able to address that? I'll start with you regarding that, and then maybe we can move on to think more broadly.
Yeah, I think that that's really a very legitimate and important concern. I think for a lot of women, I think around 30% of births was a number that I had seen occur in Catholic hospitals. There's been a tremendous growth in faith-based health systems, particularly Catholic health systems. So, and a lot of times women don't have a clue that these services are not available to them. And so these are complicated issues to manage because we want to make sure that we have availability of services. But it is a problem when the services that, that people desire are not available. I think back to kind of in my home turf of the San Francisco Bay Area, UCSF has had a very significant kind of discussion and battle in the community about bringing in Catholic systems Catholic providers into UCSF, and really making sure that the secular systems that we have provide the full range of services from IUDs to abortion services. Postpartum LARC is really an important issue as well as gender confirming procedures and services. So I think that this is an area that is very challenging, but I think that to the extent that, both payers and public payers also are engaged and involved, and we make extra efforts to inform patients, and also when mergers occur, there is community engagement so that these services are not done. These services are not merged, and then we're left with a system that doesn't provide services that we all feel are incredibly important to the people that we serve.
Thank you. Anyone have anything to add on that? That was very helpful. And Pfizer brought up in the chat as well a point about immediate postpartum LARC, particularly how there may be a response when there's overly enthusiastic providers and how they may inadvertently lead to the feeling for individuals that they are often pressured. Michelle, do you have thoughts on that?
I think this is the critical challenge that we face at this time as we are thinking about how to improve access to contraceptive care. It's crucial that we work towards that goal, to remove barriers that individuals face to evidence-based services, and to provide care that recognizes the constraints that some women face in accessing these services. And at the same time, we have to be working towards thinking about patient-centeredness, being very reflective about how our own biases, racism, classism may affect contraceptive counseling, and thinking also about our role in shared decision-making. And I always bring this up, that the shared part is the process of conveying information, eliciting patients' preferences, values clarification, and aligning the decision with a patient's preferences. The decision part is the patient's, it is not ours. The goal is not to make a decision that meets my preferences and the patient's preferences. The goal is that the decision meets the patient's preferences and values. And that can be really hard sometimes, but kind of stepping back and trying as much as we can to be cognizant that the goal is not one particular method. The goal is not a method at all. The goal is to really figure out what this individual patient desires at this point in her life course, and to help meet those preferences at that moment in time.
Definitely.
I just want to add one thing, which is I think that in many cases that our payment systems and our clinical systems are not designed to really give clinicians the time that takes. And so to the extent that we can change some of those incentives and how we pay and how we measure quality, I think will also serve as an incentive for clinicians to offer these, more patient-centered counseling services.
I agree.
Lena?
That's also the reason why patients have to come back, like post-abortion, that it can't be provided at the same time, that they have to come back later, because that will give payment for an extra visit. So I think that the economical systems and the healthcare systems, of course, that influence a lot.
And I want to add that in the United States, the National Quality Forum in the fall of last year approved a patient-reported outcome performance measure for the quality of contraceptive care. This work was led by Christine Dellendorf and her team at UCSF. And there is a 4-item survey that we can administer to patients and collect that data and really view it as equally important as method utilization as we are trying to drive quality improvement efforts. And we are hoping to do some work to adapt that measure to the peripartum context, because there are very different issues related to attribution of performance and quality, with care being delivered over multiple visits in multiple settings, inpatient and outpatient. So a lot of really interesting considerations that we still have to grapple with, but I think that is a great tool that can be put into practice at individual health centers right now to help us make sure that we are being balanced in how we are defining success.
Yeah, Michelle, what you bring up is really important, this concept of quality of care and how we measure it. And I think, there are big changes now in how we're providing care, and are we adequately measuring? So Alina, Christina, you both brought up some of the changes with increasing access to telemedicine. And so that is, really exciting and potential opportunities for expanding access to a lot of services, but it may have a backlash for influencing quality of care and how we can deliver IUD services. So in thinking about some of the changes, particularly with telemedicine, do you have thoughts and concerns about that and ways that we may try to mediate some of the impact on access, particularly for IUDs?
Yes, I mean, I'm worried because it's similar. It's easier to prescribe the pill. We know that already, and we've worked a lot to allow time and for IUD counseling and placement. Now, of course, with telemedical service, it's also much easier, of course, to prescribe a pill without any counseling at all. So I think it will be extremely important to have high quality counseling information and also access to placement. And that will depend on the setting, but I think it will be extremely important to have that in place.
Alina, do you have thoughts about this as well? Because I think from the provider perspective and then on a broader scale, what might be some of the trends in terms of access that you anticipate in ways that we may be able to address?
Yeah, I think we shouldn't view this as telemedicine or in-person care. I think we've moved to a new place now. And I think, this actually ties into the conversation, the topic around person-centered contraceptive counseling. We have to kind of meet patients where they are. For some patients, an IUD is not going to be, or at this particular time in their life, is not going to be something that they're going to want. But we want to make sure that they know that that's an option that's there, that counseling can happen via telemedicine. The telecontraceptive apps are, an option for some women who can't travel, who can't, who have children. I mean, it's like when you think about, what it takes to go to a clinician, it involves a lot of time and a lot of effort, particularly for patients who are working or who have childcare issues. So I think that we're going to really need to figure out how our system is going to have to change and respond. I think a big part of that is going to be how the payers are going to continue to reimburse. Right now, in the United States, we have, a lot of the payers have waived a lot of the restrictions. They're, trying to pay parity, but in terms of what this means for revenue for practices and for clinics, I think that's still quite an open question.
Yeah, well, we have been, clearly Paula earlier was talking about some of the benefits of immediate postpartum, post-abortion LARC. And we talk about postpartum, like the patient is there at that time and there's this immediate point of care where you can increase access and reduce some of those burdens. And now, though, with some of the telemedicine for interval LARC placement, individuals may be required for additional counseling visits that may add additional burden, though. And so while it could be patient-centered, we're trying, and there are many people that benefit from it, it could also pose barriers, I think. Do you have any thoughts on that, or ways that we could maybe not incentivize these two-step visits, or other ways that we may be able to increase point of care access? Christina, do you or Alina?
Alina, go ahead.
Oh, well, I think, again, it's, it doesn't, we want to try to have options there. We did see that a lot of actually clinicians don't stock IUDs. So even if you go to an in-person visit, it's still a two-step visit. So, we have to change a lot of kind of the systems and incentives and the structure there. But I think, with the telemedicine, I mean, you could have a counseling, visit over the phone. And then, for, a patient who wants to have an IUD, I think that's, you can then schedule that. And so there are ways that we can use these systems to make it easier and more accessible for women. And that is, around, utilizing both of these systems. And also asking patients, when they make an appointment, what would you prefer? It's kind of a basic question, but some have preferences one way or another.
So I also hope that will be possible. I mean, so here it's illegal actually to stop hormonal contraception. So we always have to have the counseling first, and then prescription, and the patient buys in the pharmacy. So they have to bring it back. So we already have that barrier in a way. But so I agree. I think if we can use telemedicine in a good way, but it also takes that we can link to clinics who can provide the placement.
I think we also have to keep in mind that some folks, as we are undergoing this rapid transformation in care delivery with telemed adoption, to make sure folks aren't being left behind. So there may be folks that don't have access to broadband internet, they don't have a computer at home necessarily, or they don't have a space between business hours of 9 to 5, either in their home or at their place of work, where they feel comfortable conducting a private visit with a doctor or a midwife. Or other healthcare professional. And I think we have to recognize also that for patients who may have baseline mistrust or concerns about our healthcare system, they may have a strong preference for building rapport with a provider in person. And so, as Alina said, I think the guiding principle has to be options to make sure that we are enhancing choices and creating policies, reimbursement practices that enhance choice for different patients.
Michelle, I think that issue is so important around some of the equity issues. I think that we don't think enough about what it means to have, the telemedicine access. Even just thinking about having, you may have a smartphone, but you're paying data by the minute. So an actual consultation could be incredibly expensive compared to doing it if you go to kind of a publicly subsidized clinic where you would get that care at no cost. So we definitely need to be thinking about those, language access as well, kind of building a system that has the equity infrastructure baked in is going to be important, I think, especially now as we're looking to expanding telemedicine.
That's a really interesting way of thinking about it, but also really important and needs to be, I think, central to the dialogue moving forward. We only have about 1 minute left before the session ends. So just to, give you all maybe a second to each comment in terms of where you think effort needs to be focused moving forward. Is there one word or one phrase or one area that you think can make the biggest impact in terms of access, particularly for IUDs or in general to really comprehensive family planning options? Michelle.
I'm going to say patient-centeredness. I think that's been the sort of relatively neglected area in quality improvement that has to be our guiding principle at this moment in time.
Christina?
Yes, I was going to say the same, because I can see that what has driven the change in many countries to provide IUDs also to young women is actually the request from the patients or the users.
And I would totally agree with that, but I really do want to add that we are still not at the point, even in a country as well resourced as the United States, that people have access to the contraceptive methods, both in terms of places that they can go and also care that they can afford. We still have financial barriers. We still have structural barriers that we really still need to address.
Well, thank you guys. I really enjoyed the session. And there's some addressing of answers in the chat. And I think that's our time for today.
All right, thank you so much to everyone who participated and presented. And please remember that if you want CME credit, you will be receiving an evaluation, which you must complete to receive the credit. And please join us on Tuesday, June 22nd for emerging technology and a look forward at what is the IUD agenda. Thank you so much.